I think that multidisciplinary approach is really important. I'm going to come to that in a moment, Vidya, but just before that, I mean, obviously it's really clear that much more needs to be done in terms of increasing
Mm.
awareness, and it makes me very grateful that we're having this conversation today. But Rachel, what more can we do to kind of improve? You mentioned about that recognition and diagnosis and the management. What more can be done, and what role does Inisio play in facilitating that, I guess?
Yeah, so I mean, I'm very fortunate that within Inisio we work with a lot of rare diseases and a lot of rare disease communities, and it's something that gives us all a sort of pleasure, and it's very rewarding to do that because of the challenges that these communities face. So one of the key challenges, and it's been alluded to earlier on today, is that trying to get your voice heard above the sort of noise of common conditions, and that's really an area where I think we can particularly excel. So we partner with organisations to be much more creative about how they communicate where they may not have much resources to put to this, to make sure that what they're saying has greater impact. So trying to think a little bit differently about what you say and how you say it in terms of channels and where you target information, to really raise profile of the condition, and also the urgency associated with diagnosis and treatment. So that's designing appropriate communications, but sort of as important in a way is really measuring the impact of what those activities are having. And if something is not working, really understanding why is it not working? Why are people not listening to us? This is so important. Why is this message not gaining traction? So really unpicking what is motivating people to pick up a story and pick up interest in the area is one thing, and we talked about a sort of evidence in terms of how you should optimize treatment approaches. So we work with sort of experts across different specialities to really bring together their knowledge and experience when there's often an absence of guidelines or sort of clear standards of care that lead to disparities in terms of the experience of care that patients experience. So really putting them in a position where they can consolidate their knowledge, their experience, and publish on that, whether it's from databases and registries, or whether it's at a case study sort of level, making sure that we're communicating and really bringing the sort of patient to life, as it were, in terms of all of the manifestations of a disease, to try and make that connection with a sort of a slightly unusual set of symptoms, to bring the disease to the forefront of different clinicians' mind. And then thinking about trials and the challenges of designing new clinical trials for new therapies in this area. We also work with organisations to look at what evidence that they should be generating, what is going to be meaningful, and it's not just from how do we get a new drug approved, what will the regulators accept, but thinking in totality of what matters to clinicians, what matters to patients. And a key part of that is making sure that the patient's voice is represented in terms of clinical trial design. So we have a patient engagement team who's dedicated to making sure that patients' voices are heard when it comes to clinical trials and beyond. So making sure that their views are represented within that is critical. And we also have a trial team that's focused on optimizing the design of studies to really maximize, again, not just the endpoints that are going to be meaningful to get a drug on the market, but that are going to be most meaningful for those who are managing patients on the conditions, so that it's very much sort of real world centric approach to clinical trial design. And that, I mean, there's lots of other ways that as an organisation that we're working, and we're always keen to partner with communities to do more, because it's rare diseases are such a challenge for those who experience them, and there's always more that we can do to further advance the cause.
Thank you. And I think it's really important what you said there about that work you do in terms of looking at impact and reassessing continually, I guess, as to is it having the desired impact? Because especially in today's world where there is so much noise everywhere about information, really making sure that, we're not just firing out, but is it landing at the right people is really important. So great to hear the work you're doing there. And to then move on to this kind of conversation around multidisciplinary team, Vidya, can you just kind of talk a little bit about what the value is in that multidisciplinary team approach for managing this disorders and the importance of getting that sort of HCP buy-in across these conditions?
Thank you, Nicola. Absolutely crucial. If we are doing the right justice to our prime service user, the patient, absolutely we need to look after, give a multi-center, like a patient-centered multidisciplinary approach. The reason is because the disorders can be quite complex and involve and sadly cause a lot of disability to the children and adults. So they would need the multidisciplinary input to be able to sort of have a good outcome. So, for example, most of these conditions require a special diet. For example, as Anna was mentioning, the GAM deficiency, they need a neurologist to look after the epilepsy, and based on the clinical features they have, they might physiotherapist, speech and language therapist, and school is also important there. In terms of educational healthcare plan, that kind of and coordinating and making sure that there's a good communication between the multidisciplinary team members is very important. And patient support organizations also play a crucial role in this, sort of in trying to link up, because I've had parents who felt they were not being listened to by the professionals and the school. So the patient support organizations were providing that key bridge in overcoming these challenges.
Thank you. And Hannah, just to kind of come back to you there, obviously, we know that just the diagnosis is just the first step really in a very long journey. What has your experience been of support post the diagnosis? How has that pathway looked for you and Tilly since that day of diagnosis?
So once her diagnosis was confirmed, her care was moved up to a London hospital and she was put under the metabolic specialist team there. And especially in those early days, having a metabolic nurse specialist, having dietitians that I could talk to. I mean, I'd stand in Tesco staring at the food thinking, oh my God, what do I feed her? All this, protein, plant protein. It was really hard back then. Now that being vegan's become more fashionable, there's a lot more choice. But 6 years ago now, sorry, it was really hard. So being able to chat through things with dietitians. She has a named metabolic nurse specialist who's fab. She's got a metabolic consultant who knows her really well. And she also has another consultant that sees her in the satellite clinic more locally with her London consultant. And just having those points of contact has been just so beneficial, because I didn't know what to expect when I had her diagnosis, but the biggest source of support for me was being able to connect with other families. So I'm part of the Association of Creatine Disorders, and I flew over to Texas a couple of months after she was diagnosed, and I got to meet the doctors that had done the research for what was the best treatment, and seeing the other families. And that's just been the best thing ever. I mean, I was very lucky to be part of SWAN when Tilly was undiagnosed, but having a name and having people that just absolutely get it is crucial. And I have made global lifelong friends. And yeah, the support was a lot better, but I found locally it almost disappeared. They were like, oh, she's now so complex and so rare. So she's not seen at my local hospital really anymore. They can't take her blood because they don't have the right machines to check what they want. Her community pediatrician team tried to discharge her because she's under the metabolic team. Locally she still needs that extra support. And it's given me more of a voice with her. So with her speech therapy, for example, I would say we haven't met a child with this diagnosis before. You don't know what she's capable of. So I really pushed for assisted communication devices, which she flies with. She's so good at communicating with. whereas they were pushing her down towards a more low-tech option and, you know, trying to put limits on her. So I felt really empowered to be more, you know, her care is patient-led. I choose what she does, and, you know, I feel that we have a very collaborative approach to Tilly's care with all the teams involved, because I'm able to talk to other families and see what works best for them. So it's just been, yeah, I went from feeling very alone in the world to feeling like, you know, there are people that get it, and realizing that there's so many other, like, I didn't know, I have a friend that's got 2 sons of PKU, and it never ever crossed my mind until he had a metabolic disorder. So to find out how many there are, I mean, I was adopted into a Facebook group for children with urea cycle disorders, just because they're low protein too. So they've been a really good support. Just having that metabolic community it changes everything. It's really wonderful, because having a special child can be so isolating. So just having that community and having that support and, you know, having that name for what it is crucial.
And it's paying dividends, because it's allowing you to push her to be the best version of herself through, you know, what you can see is possible for her to achieve. So aside from that personal connection, it's just giving so much back to her. And it's lovely to hear that Tilly's doing so well and finding ways to have her voice, which is really important. So I think that segues really nicely, Jonathan, on to you. And it would be nice to kind of hear a little bit more. You've touched on it throughout, but, you know, the role of Metabolic Support UK in terms of supporting patients. And also, I know you mentioned your Thoughts into Action report. If you can give us a little bit more detail about what that really all entails, that'd be wonderful.
It's a big question, but no problem at all. So I'll give a brief overview of the Thoughts into Action.
Thank you.
And then I'll lead into some of the work that we've done because of that. So the Thoughts into Action research, it took a grounded theory methodology. So basically what this does, it's like a qualitative research method, and this is where research conversations are led by participants. So for example, we didn't have any structured interview questions. We just let people talk, and then through the conversations, we generate a theory. So we work with a grounded theory specialist who works in this sort of area. And this 57 people chose to take part in the study. So this was 31 parents and carers and 26 people living with an IMD. This represented over 30 individual IMDs. So we got like quite a nice sort of cross section. And when you think as well, like we had like quite a wide and varied people like come along. It was like different ages. We had different ways to engage with the research. It was really nice. So the overarching theory was that people with an IMD have a carefully woven net of structures, and this nurtures, protects, and develops and sustains them, enabling people to live a fulfilling life. Because at the end of the day, people just want to live. They just want to have as best a life as they can. So the factors identified as key to contributing to this net was identity, employment and benefits, food, healthcare, transitions, and mental health. So if there's gaps in these areas, people can fall through that net, and this can lead to a worsened quality of life with potentially like worsened health outcomes, just a lower quality of life sort of thing. So this informed our work moving forward. It's like, okay, and when you look at it as well, and look at the UK rare disease framework and stuff like that, a lot of the focus as well, and when we're looking to people looking to develop drugs, is what's the healthcare benefits. And whilst healthcare was one aspect of what was important to people's mental health, it was a lot of the things that were just in allowing people to have a fulfilling life, such as I mentioned, the employment and benefits. So in terms of the work that we've done, so Metabolic Support UK, we aim to strengthen this net to ensure our communities are supported and can achieve that quality of life. So we offer individual support. So Helen, who's been with us for over 20 years, she provides tailored individual support. So people come to her with every different thing under the sun. I don't know how she does it. And she's done all sorts. It's a bit crazy, but she really supports people on that individual basis. And I actually had an email this morning, which was really nice. Someone just got that new diagnosis, late onset of inherited metabolic disorder, and they've come to her and they said it was a lifeline, and that's just really nice. So, and then we also advocate for people with IMDs. So as I mentioned, we're doing the Think Ammonia campaign. So this is aiming to improve outcomes of hyperammonemia. We also respond to consultations. We empower people with IMD. So we've developed the Research Ready Hub. Clinical trials can be they can be hard to understand, and there's a lot of jargon. So we're trying to improve that. So we've developed a hub for people to go to, really sort of easy to access kind of information. What's a clinical trial? It's got people talking about it. Like, so for example, where we've got like clinicians and stuff talking about clinical trials, and that'll be getting uploaded in the next few weeks, which will be really nice. We've also got an advice hub, and then we build communities. So Hannah's mentioned the power of community, and this is a big focus for us, especially in this year, actually. So we've got a big focus on community, building those communities, improving that connection, but also looking to connect people from around the world. We don't just want to focus on the UK. We do offer support to people around the world. You wouldn't guess it in the name, but yeah, we get a lot of people coming to us from around the world. So it's like, how do we build the communities out there? And just basically take that benefit that we've seen from our people and like take that away. So what are we doing now with TIA? So we've used the insight gained through the research to respond to consultations. So for example, transition to adult care. There was a consultation last year that we responded to, and some of the sorts of recommendations that we've made have actually been incorporated. So they said they're going to action that, which is really nice. So one of them was, I think Vidya mentioned earlier that, so it's really important to have that coordination of care, very important, and it's very well defined for paediatric care. But people find that when they get to that adult care in that period of transition, even if they have, which often they don't, a well-developed transition plan, they might be transitioning into adult centres where there isn't that expertise, there isn't that sort of coordination of care. People can often, that's where people can fall through that gap, and then people can be lost to follow-up, and then that leads to worsened health outcomes. We've obviously launched the Think Ammonia campaign. We're also proposing a Living Well symposium in September. So this is aiming to change the conversation around living with a rare disease, because 95% of rare conditions, as we know, don't have an approved treatment. So it's like, okay, if that's the case, why is everything talking about treatments, healthcare, this, that, and the other? What can we do in the meantime to improve those people's everyday quality of life so that they can do things? So one of the people said to us, I don't want much. I just want to have support so I can charge my electric wheelchair, so I can drive to a coffee shop and just sit there and watch the world go by. Such a simple ask, but he's not able to do because he can't access that support because there's little known about his condition when he's actually trying to get that support. And then we're also doing things like visiting IMD clinics, producing resources for access and benefits and money management. And then we've also doing things like the Disability Benefits Consortium, so that we, as a rare disease organisation, are also engaging with larger sort of movements and different organisations outside of the rare disease space, that we're not working in silos, so that we can increase the profile of inherited metabolic disorders and just change the sort of conversation around rare disease and really drive forward people's quality of life. I think that's it.
Fair to say you're quite busy then, Jonathan. Thank you so much for that. I know, thank you so much for everyone that's bearing with us. We're right at time, but there are a couple of questions that I'd really like to get through that were submitted before. So if everyone's okay for a few more minutes, I've tried to kind of pick through the ones that I think could really get to. The first one for you, Vidya, is, should there be a liaison between psychiatrists and the metabolic team as part of that multidisciplinary approach, which I thought was a really good question.
Yeah, very good question. I agree. And they form a crucial part of the MDT, looking after the child or the adult. The reason is, again, many of the metabolic disorders present with psychiatric manifestations. And it's important, the psychiatry, there should be a close liaison and understanding of how they're present to be able to adequately treat the manifestation. Like we do notice self-mutilation or self-injurious behavior in these conditions. So the psychiatrist would need a special sort of, awareness and expertise in metabolic disorders. So absolutely crucial to have psychiatrists, but as anything in the NHS, it's very difficult to source them. So yeah.
I mean, it's encouraging to see that where we have commissioned services, typically that is becoming part of the embodied, but of course, for all those conditions that don't fall within that, it can be a real kind of, falling through the net, but that's really great. Thank you. Another question here, I'm not sure, this might also be for you, Vidya, but possibly Jonathan as well. Does a diagnosis of a severe mental illness eliminate patients from trials or treatment?
So it really depends on the severity and extent of the mental illness and what exactly they mean by mental illness. If it comes to the clinical trials, all clinical trials have a set inclusion and exclusion criteria. So it is very clear whether they're excluding or including based on the neurological or the mental health aspects. If they are not as a part of the exclusion criteria, so it should not affect their participation in clinical trials. Whereas if you come to treatment, I don't think they should be excluded from treatment, because mental health illness or aspects are a part of the manifestation. So we should absolutely try to sort of treat those. For example, if anxiety or sleep, insomnia, not being able to sleep, so those need treatment. Yeah.
Oh, thank you. And then there is another question from someone who's asked whether there are pediatric neurologists that specialize in dystonia triggered by inherited metabolic disorders. So just to say to that one that we will have some contact details coming up at the end of the session. So perhaps if whoever generated that question could reach out to us. If not, Becky will reach out to you and we'll connect you so that we can get you some contacts there rather than doing that over the session. I think the rest of the questions that have come in, we've probably covered throughout the session, which is really great. Yeah, fantastic session. It's just been so informative. Hannah, I really appreciate you being so candid there as well. And I think, Jonathan, it's incredible to see the great work that you guys are doing across the whole sort of ecosystem of this disease group. So thank you so much. So yeah, big thank you to you all, to Rachel, to Jonathan, to Vidya, and of course to Hannah for sharing your experiences so openly. I think it means a lot to everyone to hear that sentiment echoed, which a lot of people are going through themselves. So thank you. Thank you all for listening and staying with us. Sorry, we went slightly over, but thank you for your patience and for your great questions. Any that we didn't get to, we will endeavour to get back to people individually after the session. Please do feel to reach out if you have any questions after the session, and we can direct you to different members of the panel. We'd love to hear from you with any feedback. And thank you all very much and have a great rest of your day. Take care. Bye.